Es el turno del profesor Smith, que nos va a hablar pues un poco desde el punto de vista también mixto de microbiólogo, clínico, pediatra e infectólogo.
Thank you, Jesus, for the very nice introduction. And I'm at a different meeting every week at least, and with different locations. But for this year, this is the most beautiful I've been to. This is really so inspiring. You can feel the Holy Spirit with us. And I'm very grateful for the organizers to invite me. I had a chance to visit the city last night, a little bit the old city. This is really beautiful, and I guess I have to come back with my wife someday, and maybe not too late, not too far from now. So thank you very much again, and the topic is pneumococcal conjugate vaccines for all ages, and I start where I started last year, and this is the pneumococcus. And you see the large polysaccharide capsule around it, and the bad news is this is a virulence factor. This inhibits phagocytosis, and if you have no capsule, you don't get sick. But the other virulence factor, the other mechanism for virulence is to allow colonization. So by downregulating the immune system, the capsule is allowing the organism to colonize us. This is very important because this means a polysaccharide vaccine is not a good vaccine because it downregulates your immune system to allow for colonization. And this is the opposite of what you want. So the polysaccharide vaccine works. It has some effectiveness. I will show you that on the next slide. But only because you use 25 micrograms per antigen. The conjugate vaccine has only 2 micrograms per antigen and 4 for the 6B. But it's 1/10 what you need for immunogenicity. So there is a qualitative and quantitative difference in the vaccines. And again, the polysaccharide may be not a good idea to use as a vaccine. And I have some data that were just published recently from the United Kingdom. And the paper is from Andrews and co-workers, published in 2012. And I'm sorry, what you see here is in red the PPV23 16 serotypes that are not in PCV7. And with the introduction of the vaccine, the serotypes, well, you may say they go up, but let's say they don't change. And vaccination coverage in adults, 65 plus in the United Kingdom, is 70+%. So you see no effect on a population basis. Whereas with PCV7, this is the blue line, you see a reduction of the serotypes. And I think the biological background, again, is the vaccine is using the polysaccharide, which downregulates your immune system, and it allows for colonization. And if you allow for colonization, you cannot reduce disease in the end. There may be individual protection. And now in this paper, they calculated this. And to summarize this, there is no evidence for effectiveness against pneumonia in the United Kingdom. And they have been using these vaccines for many years now with 70% coverage, approximately. The overall effectiveness against invasive pneumococcal disease is 24%, but this is limited to 5 years. After 5 years, it's 0. There is no effectiveness after 85 years of age, and there is no evidence for effectiveness in 13 serotypes of PPV23, which basically makes it a 10-valent vaccine, not a 23-valent vaccine. In the end, you have to think of how to use this vaccine. If you use it, there is some benefit, as it is shown here. But if you want to know the details, read this wonderful paper by Andrews and co-worker from the United Kingdom, 2012. The conjugate vaccines were highly effective, and Dr. Aguirre showed you all the data, and very nice data from Spain here. The basic principle is there is a T-cell response. You use the polysaccharide as the antigen, as the target for the vaccine, but by linking it to a protein, you get a qualitatively different immune response, which is a T-cell response. You get a memory cell, and you don't get a memory cell with the polysaccharide vaccine. The biological effects of this are tremendous. They include a memory response, great IgG response, carriage reduction, and this is why you get herd protection if you have high coverage. We know already 2 years after the introduction of PCV13, there is herd protection in many countries that have introduced the vaccine for children, but you see the herd protection in adults. So the T cell response is really the big difference. It's a qualitative difference. Again, 25 micrograms versus 2 micrograms. That must be a difference, particularly when it comes to efficacy. This summarizes a little bit the immunology behind the vaccine. You have the naive B cell that differentiates into a plasma cell and a memory cell. And again, the memory cell is what you don't get with your polysaccharide. Children have very many naive B cells, but they don't know what to do. They cannot give you a good antibody response. They have to learn how to respond. And it takes 2 years before they really know. So you need 3-4 doses before you really get efficacy. In the elderly, you have very few naive B cells, and this is why titers after vaccination are usually lower, so it's another difficult situation. This is the background, and from there, the concept we have today is the reservoir of the pneumococcus is the young child. It gives the organism to the elderly, it transmits the disease. Now, if you reduce colonization with a conjugate vaccine, you will see herd effect. This is effect number 1, right? And the polysaccharide doesn't do that. The antibody response to vaccination is low early in life and late in life. And this is why you see most disease early in life and late in life. And this is what Dr. Aguirre showed you very nicely on his slides as well. And this is why you should vaccinate early in life and late in life. And now I try to convince you to vaccinate some patients in the middle of life. First look, it looks stupid. Why do you want to vaccinate here when morbidity is lowest? Doesn't make any sense. The answer to that, and I'll come to that in a minute, is risk subjects. It's a very, very short message. So early in life and late in life, we vaccinate because of IPD, otitis media, pneumonia. But in the middle, there is not much disease left unless you have a specific risk factor. Let's go to adults first to summarize what we have the license for. The license of PCV13 adults was based on immunology only. We have no clinical data yet. They will come early next year. In red, you see vaccination with PPV23. After 1 dose, you get that titer. After a second dose, 3 to 4 years later, you get that titer. It's a little bit lower. It's called hyperresponsiveness. You have no memory. I told you all that last year. In contrast, PCV13 gives you higher titers. The titers are higher if you start vaccinating earlier in life, so it may be a good idea to start at 50 and not at 65 or even 75. In any way, this is the data that the license is based on for PCV13 in adults, and new data will come for clinical efficacy next year. At this point, we don't have any efficacy or effectiveness data in adults. The study that will be available, hopefully early March next year, is called CAPITA trial, a trial on community-acquired pneumonia of vaccine type in elderly subjects. It's a double-blind randomized study. It's 85,000 subjects that were randomized in the Netherlands, and they received either placebo or Prevnar 13. Again, all the cases are in. We have enough cases for the analysis, and now 85,000 subjects have to be checked if all data is available. If no urine was missed, if no blood count was missed, if everything is in, then unblinding will happen. And this probably will be very early in January next year, I hope. And we hope to present the first data at ISPPD in India in the second week of March next year. So right now I don't have the data, and I guess next year I will be able to show a little bit more. The end point of the study is vaccine serotype pneumococcal community-acquired pneumonia, invasive or not. The secondary endpoint is vaccine type invasive pneumococcal disease or non-bacteremic pneumococcal community-acquired pneumonia, which is then non-IPD type pneumonia. The reason to use placebo is very evident. You want to have efficacy. The reason not to use PPV23 is it's not working. There is enough evidence, according to the government in the Netherlands, that it's not working. And they don't recommend it, and that's why we could do the trial there. They don't use it, and that's why we could do the trial there. And in addition, if you want to have more information on that, there is one paper by the WHO from Haas and co-workers to say it's not working against PPV23 doesn't work against pneumonia, or there is no evidence for efficacy. And the second review, it's a meta-analysis from Cochrane. So there's a Cochrane analysis from January 2013 that also nicely summarizes there is no evidence for effectiveness of PPV23 against pneumonia. So this is the end point, and again, we don't look versus PPV23, we look against vaccine serotype pneumococcal community-acquired pneumonia. Now, how do you diagnose pneumonia? The most simple thing would be to take a 20C syringe and a number 1 needle, and if Jesus has pneumonia, I take the syringe, I put it in his chest, I suck a little bit, and then I give it to Dr. Fornella and tell me the serotype, and then we will know what it is, right? But for whatever reason, we don't do this. WHO has done this with malnourished children in Africa. Complication rate is close to 0, so I cannot tell you why we don't do lung punctures. We puncture everything, but not the lung. I think it's culture, or I guess if you would do it in your hospital, people would stop coming, right? I mean, I don't know what it is that we don't do it. So how do you diagnose pneumococcal pneumonia? The answer is we have developed an antibody test. It's based on Luminex to detect the polysaccharide that causes pneumonia in the urine. There is a threshold. If you're colonized, you have very low concentration. If you have pneumonia, you have a significant higher concentration. And this is a published and accepted test for distinguishing between colonization and pneumonia. It's published last year by Pride and colleagues, and it's accepted by FDA in the United States and by EMA, by the licensing authorities in Europe. So this is the test we use, and then looking at the urine, for someone who has pneumonia, we can say this is serotype 1, 3, or 19A pneumonia. This is the backbone of what we have been doing. Now back to using the vaccine for all ages. I told you very young, that is by age you have a high risk. 50 plus, I don't call it the elderly because that's me as well, right? I'm 50 plus, so I call it 50 plus. Second half of life is another word to use, but never say elderly. Nobody wants the vaccine if you say it's a vaccine for the elderly. So 50 plus, and now why vaccinate in between? The reason again is risk. And there are quite a few papers out there already, and more are coming to show you the increased risk for pneumococcal disease with different organ diseases. This is a study, again, from the United Kingdom, from Van Hoek et al., published in 2012. In the age group 2 to 12 years, the incidence of invasive pneumococcal disease is 3.9 per 100,000. So this incidence is set as 1. 16 to 64, this is the age group we are looking at, the median age group in between. The incidence is 5.2. The odds ratio is set as 1. 65 plus, the incidence is 18. The odds ratio is set as 1. Now let's assume you have chronic lung disease, COPD, cystic fibrosis, asthma, I hear some coughing here, maybe you're a smoker, then you have chronic lung disease, right? So let's look at lung disease, what happens. The incidence goes up to 50, and this is where we started recommending PCV7 for children. It was somewhere, looking at wherever you looked in Europe, 50, 60, 70 per 100,000 cases, and this is where we started vaccinating. And the odds ratio is 12.7, so you have a 12 times higher risk to come down with invasive pneumococcal disease if you have chronic lung disease. 16 times higher if you're in this age group, and here the risk is 90, the incidence is 90 per 100,000. This is beyond what when we started vaccinating children. And in the elderly, they already have a high risk, then this is why the increases are not that high. So this is very nice data summarized in this table. The table is confusing. I'll show it to you anyway, but don't look at the detailed numbers. It's a great publication if you are a specialist in cardiology, in liver disease, diabetes. This is the paper to read to look at the individual risk for pneumococcal diseases. And there are more papers out there that all have the same message, but this is the one on the best data available, and it's from Europe, and it is really methodologically a very nice paper and worth reading. Now, we do have data to show that if you have chronic organ diseases, the immune responses are the same. If you look at the different bars in different colors, serotype 1, if you have chronic pulmonary disease, cardiovascular disease, or diabetes, as compared to the black line, the lines are roughly the same. Numbers are small, but still, there is no reason to believe that if you have diabetes, your immune response would be impaired in a way that you're not protected from vaccination. So good to know, that is the data that we have. We also have data on sickle cell disease, and just to show, I won't go through the slide, this is just a placeholder to tell you the vaccine is working in subjects with sickle cell disease. And that may be a little bit of a higher problem in Spain than in Finland, where this is very, very rare. But I understand now, due to migration, the sickle cell problem is increasing, and many countries, they just start looking, particularly France. In other countries, they don't look at the problem, and they should, because these immigrants come to Europe, and their children are maybe 5, 6 years old, though they escape the pediatrician and they are not vaccinated. So, you know, this is something that clearly needs to change. We need to vaccinate children of immigrants in the appropriate way if they have risk factors for pneumococcal disease. This is data on HIV-positive subjects. I briefly walk you through this. For serotype 1, after one dose you get a nice response. Titers go down by a time. Second dose, nice response. Third time, nice response. It's all about the same. Serotype 9V, with each additional dose, the titers are a little bit higher. Most serotypes in HIV-positive subjects are in between. It's about the same response with each additional dose. So now you can say, I'll give my AIDS patients 1 dose, 2 doses, or 3 doses. It's up to advisory boards to look at the detailed data and then make a decision for your country. Do you want to give 1, 2, or 3 doses? For us, it's open. It's your advisory boards, your experts to decide. So what we know now is young and old age are the most prevalent risk factors for IPD. There are also risk factors for ages 6 to 49 years. And if you are a specialist in cardiology, liver disease, diabetes, you should know about that. And this is why the vaccine is now licensed for all age groups, including 6 to 17 years, actually also from 18 to 15 years, and from all ages as of 6 weeks, basically. We have data on risk groups with regard to immunogenicity, and there is no reason to believe that the vaccine would not work. We will have additional data by the end of the year or early next year. So I think it's now up to you to come up with recommendations in each country by scientific societies to make sure that subjects at risk for pneumococcal diseases are vaccinated. Such risk recommendations are available in basically all European countries, including in Spain. So they are out there, and the question then is, who's doing it? The problem is always you have a recommendation, but what about implementation? And I think particularly for the pediatricians here, we have to get better at telling others how to do the vaccination and to look why it's not done in many instances, why subjects with asthma or COPD or smokers are not vaccinated. And I think this is just on best practices, and I have no idea how that could work in Spain, but we have experts here who will know. Now, one question I want to address in a little bit more detail is, how do you get a license for an age group between 5 and 50 years if there is no license available and you have no clinical data? And the one short answer is by prediction. And the immunological word for that is bridging. You have data in the very young, and you have data in the very old. You produce in data for the age group in between, and you call this bridging. So what you do is you vaccinate age group 5 to 50. You look at the immune response. You say it has to be non-inferior to the comparator, to another age group where you know the vaccine is working. And then by looking at a non-inferior immune response, you bridge your immunological results to efficacy results, and you say if the immune response is the same, efficacy is the same. And this is the basis for the license for all ages that we have now for PCV13, and I'll show you that with a little bit more detail. For children 5 to under 10, we do have data to compare to PCV7 serotypes in the very young. And then we compare the 5 to 10-year-olds to the age group 10 to 17-year-olds. And then again, you can see that there is non-inferiority and you get nice responses. And this is why you then call it non-inferior, and then you bridge immunology to efficacy. And safety is quite simple. You look if subjects accept the vaccine or not, if they come back to you for the second dose, or if they come back for the follow-up blood drawing, whatever it is, and then you look for side effects, you ask them, you collect the data, and then you know the safety profile of your vaccine. This is the 7 serotypes comparing 5 to under 10 to children in the second year of life. And what is done here, you divide the geometric mean titer that you receive in this age group by the geometric mean titer you receive in this age group, and the ratio is 3, which is well above 1, and this is called just non-inferiority measuring. And what you get is just a ratio to tell you your immune response is even better than if you were in the age group in the second year of life. So this is very nice data in the 5 to 10-year-olds for the 7 serotypes. That is great. You get very good data. And then again, you bridge to efficacy. Now for the additional serotypes, you just look PCV13 after a toddler dose. We do have effectiveness data for that. And then again, the ratio here is above 1, and the 95 confidence interval are quite narrow. And again, you can say, so in this age group, also the additional serotypes, nice immunogenicity, so it will work. That's the basic principle. The same you can do now for 5 to 10 versus 10 to 17. It gets a little bit boring, but you know, this is the way it is, and this is the data. Nice, nice responses and nothing to worry about, and we got the license based on that data. Now for 18 to 49, the license is based to comparing to adults 60 to 64 years, because this is where we had the license at that time. And again, if you look here, you get nice responses well above 1 for all the serotypes, except for 3 where it's just 1. But other than that, you get nice responses in 18 to 49-year-olds. This is how it came to the license. If you're interested into the details, at some point, all of that will be published on the website of EMA, and you can just go there and download the report of the reviewer who had looked at all these data, and you can read his conclusions from there. Now, this is about adverse events. Local adverse events are tenderness, swelling, redness, and if you look at any of these side effects very clearly, it's up to 90%. But most of this is negligible. You don't have to worry about it. No, there is no really safety concern. But I guess if you ask every subject in a trial 4 weeks after he received the vaccine, did you observe anything? Everybody will have observed at least a little bit of something, and then you get these high rates. Nothing to worry about, very similar to other vaccines, and patients who were asked found that this vaccine is very acceptable with regard to reactogenicity. This was local reactions. Then there are systemic reactions, and I think you shouldn't look at the numbers. In summary, nothing to worry about. It's fevers or whatever you look at, there is nothing to worry about compared to other vaccines. It's in the same magnitude of frequency. How about unsolicited adverse events? You always worry that the vaccine could cause something that you don't anticipate. Let's say endocarditis or Kawasaki disease, multiple sclerosis, whatever. So you always look very careful at unsolicited severe adverse events. And again, looking very closely at the whole database, at this point there is nothing to worry about. The other message is there will be a couple of thousand subjects who will have received the vaccine, and you cannot anticipate that rare serious adverse event can be detected if you only have a couple of thousand subjects. So what needs to be done as a follow-up measure after the license of the vaccine, Pfizer has to submit safety data every 6 months on everything that happened to the authorities to be sure that if there is a concern, it will be picked up. The good news is 600 million doses of PCV7 and PCV13 have been sold to date. This is a huge database. I would not know any other vaccine, I may be wrong here, with such a big database in just such a short time, 13 years now. 300 million doses PCV13 to date, nothing to worry about. Again, we write these safety update reports basically twice a year, and just yesterday on my way here, I had a telephone conference for the next 5-year safety update report, which is due mid-next year. So, from all we know, there is no safety concern with PCV13 in any age group to date, and nothing to worry about. And if you like the details, go to the publicly available assessment report of the EMA, which you can download from their website. What have we learned from looking at all the data that we produced in all the studies that we did? And one of the messages that I got here can be seen in this slide. Let's take serotype 4. If you're an infant, you get 3 doses, this is your titer. If you are a toddler, you received an additional dose, this is your titer after the dose in the 2nd year of life. 6 to 11 years, 1 dose, this is your titer. 12 to 18, 1 dose, this is your titer. The message is, the older you get, the better your immune response. That's great, right? The older you get, the better your immune response, and that is true basically for all the serotypes. The pattern is the same. Very good news, and 1 dose is enough for all subjects up to 18 years. The bad news is, from an immunological point, aging starts at age 20 to 30. Let's take serotype 4 here, 18 to 29, 30 to 39, 40 to 49, 50 to 59, 60 to 64, 65 plus. The titers get lower. So it may be a good idea to get your vaccine while you're in the 50s and not when you're in the 60s or even 70s, because protection may be better, at least the immune responses are better, and very clearly it has to do with your naive B cells. You have more naive B cells available, they are not used, you have not been colonized with the pneumococcus, and it didn't take away your naive B cells to allow for colonization, so you get a much better immune response. So the whole picture is closing now, the whole puzzle we understand a little bit more now. If you are colonized, you get lower titers because your immune system already is no longer naive and you've had this stupid antibody response to colonization, which does not protect you. So this is, again, the message is, if you're young, with age, immune responses increase. If you're older, as of 30 at the latest, immune responses decrease. Very nice learnings from all the studies for licensures that we did. And this is, I've been looking for that type of data for decades, and now I have that data, I'm very proud of that. Now, what do we do with all that? I guess the short summary will be, number 1, there should be age-based recommendations. Under 5, above 50, 65, wherever you draw the line, look at your local data that is available. Dr. Aguirre, Dr. Fonella, you just look at what is available and then you draw your line, age-based recommendations. In addition, in between, the risk is low. My daughter is 20, I won't vaccinate her, it would be stupid. If one of her friends has asthma or, there I would recommend vaccination, very clear. So this is a risk-based recommendation. Another message after all the studies that we did is, and actually that is even in the label by the licensing authority, you should always use PCV13 before you use the polysaccharide vaccine. The reason is memory response. With the conjugate vaccine, you get a memory response, and if you use the polysaccharide thereafter, it will be like a booster, you get a booster type response, and you may get an additional protection against the 2 serotypes where PPV23 has shown some effectiveness, so you may get a little bit more protection in addition. If you want that, that would be possible. But again, I think these are the 3 options or the 3 messages to consider after 2 decades almost of pneumococcal vaccine research, particularly with regard to conjugates. There are recommendations out there in Spain, which you probably know better than I because you can read Spanish. This is an English translation of what you recommend. Basically, it's the same what I told you before, and it comes from the scientific baseline there. If you are naive, you should PCV13, and then if you are immunosuppressed, you should receive PPV23 8 weeks later. Or if you're immunocompetent and you have a risk, then you should receive PCV13 only. If you've previously been vaccinated, then you should receive PCV13, as it is shown here on the slide. Very similar recommendations in the United States and in some other countries. If you look at the map of Europe, each country and even some regions have different recommendations, so it's impossible to put it all on one slide. So I think the pneumococcus is a very nice Christmas tree, but it's like a very nice Christmas tree, but all the parts are here and there is a ball here and there, and what I did is I dissected the Christmas tree, and now it looks much nicer. Thank you very much for listening to me.
Gracias, profesor Schmidt.